Good morning, everyone. Welcome to the session, an extreme makeover patient partner edition. It's going to be pretty interesting. I'm not even sure what that's going to look like, but we're going to find out shortly. I'm Bruce Harries. I'm on faculty with the council. I'm the moderator for today's session, so I'm pleased to be here. I wanted to start by acknowledging the land on which we're gathering is on the unceded territory of the Coast Salish peoples, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And so for today, we have rapid fire, so it's really three. We have our presenters up here who will be introducing themselves before they share their what they've learned and what their topic is with you. So we have three presentations. So the format is really to have 10 to 12 minutes of talking, some time for questions, and then we'll switch. And so we're here for the next 58 minutes or so, and we'll go along. And any questions before we get started? That could be from our presenting group too. If you have any questions you want to say now or forever hold your peace, right? Is that? Well, I'm really pleased to, our starting group, so designing HeartHub, Cardiovascular Health Information Hub for patients by patients. So that's our starting point, right? Yes. Okay. Do you want to come up and thank you?
So thank you, everyone. So the actual start will be our shared commitments. So thank you all for attending, and the presentation is up on the slide. And just a quick note before I start, I had the privilege of meeting Bruce Harries in 2005 when I was just starting out in quality, and it's very much a privilege to be moderated by yourself. So thank you.
Even if I got the order wrong.
It's completely fine. It's quality improvement. It's what we're about. It's okay. It's okay. So how's your day so far? Yay! And we're about to make it better. So thank you very much for this opportunity. We look forward to sharing the work that we did together. My name is Mandy Lindsay, and I'm the leader of Patient and Family Centered Care for Fraser Health. And this is Rosemary. She's a patient advisor and also a member of the Fraser Health Regional Patient and Family Advisory Group. Next slide. Oh, that's me. I have control. Okay, so first off is that we'd like to share that we have nothing to disclose other than we are uber happy to be here. In 2016, Fraser Health was accredited. We had the survey done by Accreditation Canada, and we did miss the mark on a couple items, one specifically related to the leadership standard. So we did not do a really good job of sharing with patients and families about their rights and responsibilities. So we were like, okay, we need to do this better. What we did notice, though, however, was there were examples of pockets of work where these were shared with patients and families on a unit level. So, for instance, in a unit welcome package. But where we did need to improve was at the governance level. A little bit of background is that this picture is of the Fraser Health Regional Patient Advisory Council. We shared with them about the unmet leadership standard, about not communicating with patients and families about their rights and responsibilities, and so they decided to take this on, and we asked if we could partner to do so. And so when planning the work plan and objectives for the advisory council, they said yes, and we added this to the list. A literature review and an environmental scan was done to help inform the development of the rights and responsibilities document. Then we also pulled internal Fraser Health data, so patient safety learning system data, patient care quality office, the good, bad, and the ugly, because that's how we learn. And then we also utilize the satisfaction results from our real-time patient experience survey. We turned our challenge into an opportunity. The Patient Advisory Council looked at the literature and at the environmental scan, and the whole idea about creating a rights and responsibilities document didn't quite sit right. They wanted more of a reciprocity agreement. So what can we all do together to support care and experience? So in such, they did create our shared commitments. It's a reciprocal agreement between the person receiving care and their family, as per how they define it, and the care provider. It's a partnership. an opportunity to co-create and build meaningful relationships. Oy, oy, oy. There we go. Our Shared Commitments is a pledge created by patients, families, staff, and clinicians for patients, families, staff, and clinicians. The Our Shared Commitments include domains such as dignity and respect, safety and cleanliness, communication, partnerships, understanding, and privacy and confidentiality. On the bottom here, you'll also note that we do, although you may not be able to see it, do include a definition of family, and that is, as anyone important to our patients, residents, clients, whether they are related or not. Now, we wanted to make sure that both with building awareness and implementation, we wanted to use a top-down approach, but then also a bottom-up, as we learned this morning. We wanted to make sure that the principles of inclusivity and accessibility were included, that we wanted to create an emotional response, and that we wanted to integrate our shared commitments into everything that we do, how we interact on a daily basis, how we do our work on a daily basis, and how we support care and experience on a daily basis. So for accessibility and inclusivity, our Shared Commitments was translated into multiple languages, including Arabic, Farsi, Chinese Simplified, Chinese Traditional, Korean, and Punjabi. And that helps to serve the population that we serve within Fraser Health. Also, when building awareness, we utilize staff and patient stories to make our Shared Commitments live. It's not something that we want to sit on a wall or on a shelf. We want to make it alive. And that's how we'll make generational and evolutionary change. Perfect. Now, with regard to integration and how we do our work, part of we included our shared commitments in the bottom-up discussion. So for instance, in releasing time to care huddles, in staff meetings, in all education, orientation, and leadership development. So we tried to interweave it within everything that we're doing within the organization.
So Mandy's covered off everything, and I just want to say just a few things just from the patient partner perspective. And excuse me, I'm not much of a public speaker, but I just want to say it was a very meaningful experience for the patient partners who were involved because our experiences allowed us to identify some of the common themes that we wanted to ensure would be included in the document, such as dignity, respect, and involvement in our own care planning and treatment planning. And you'd think that some of these values or behaviors would be obvious and not require mention, but in a busy hospital environment, they can be overlooked. And we just wanted to ensure that they would be included. The staff who worked with us to develop this document supported these themes. So after many hours and several months, it took a long time going back and forth, but the wording was fine-tuned into the current document. And we're all really proud to see this document displayed in our hospitals, and we all appreciated the opportunity to work collaboratively with the staff at Fraser Health in preparing it.
Awesome, thank you. And so we know that everything is better when we work together. So thank you very much, and we look forward to any questions.
Thanks, Rosemary and Mandy. So, any questions? I think the best way to do this is if you just write them on a $20 bill and then
Absolutely.
Seriously, right? Any questions, thoughts from the
I
group?
just said one thing. My brother went through a health thing. My brother went through a health thing, and it was the little things, like someone saying he wants someone to fall up tomorrow, that made a huge impact. So thank you for including those.
Awesome, absolutely. And if you have any questions later, I'll be around the conference both today and tomorrow, as will Rosemary. And I do have cards, so always feel free to email as well. Email or call, or I like, person-to-person interaction is great too. Hey.
I'm Lisa from Fraser Health as well, so really excited about this because I understand this is
Absolutely.
And I was really curious if you're planning to measure or get some patient responses to this, say, after the fact or a year or two.
Absolutely. And so part of the evaluation strategy is to evaluate from multiple perspectives, and patients and families is some of those. And utilizing the real-time patient experience survey to gather that, and then to show a difference between baseline of what it was like prior to implementing or building awareness about the Our Shared Commitments, and now after implementation over a year and so. So definitely. Thanks.
Are there any other questions? Well, thank you again.
Perfect.
Designing the HeartHub. Kim and the team. Yeah.
We're all in this together. So my name is Kim Miller, and in addition to being a senior leader at Sunny Hill, I have the pleasure of being the knowledge translation lead at ICV Health. And I'm here with Dawn Grant, who has been an integral part as our patient partner in HeartHub, and also Jess Maiorino, who is our operations leader and is the co-lead in this project. And I'm going to have to use this appropriately. So backwards. All right. We have nothing we need to disclose, but we're really thankful to Heart and Stroke Foundation of Canada and with some matching funds from Cardiac Services BC who supported this project. So I'm going to talk about the knowledge practice gap that we were trying to address, how we co-designed the website, how we evaluated, what we learned along the way, and what our next steps are. So let's talk about the knowledge translation gap that we were trying to address. There is strong evidence that people who are living with diabetes are less likely to die and less likely to have heart attacks if they have bypass surgery as opposed to stents for treatment of their multi-vessel coronary artery disease. But despite this, there's significant variations in practice patterns across British Columbia. And we know that in some centers, these people are more likely to receive stents as their treatment. To better understand this, we sought the perspectives of people out there that are involved in this. So we talked with frontline healthcare providers leading educational outreach sessions with cardiac services teams to better understand what the challenges and potential solutions were to putting this evidence into practice. And we certainly learned that patient preferences mattered. We also spoke with patients and families about their perspectives, what their information needs and preferences were. And we came to understand that there were important things to be understood about how people could participate in informed health treatment decisions. I'm going to hand this over to Dawn Grant, and he's going to tell you about his experience in heart treatment.
Thanks, Kim. So my story is, it was late in January of 2008, and I was at one of my regular spin classes at my community center in Peachland, and we had just started a sprint regime, and in about 10 seconds, I could not do another revolution of the pedal. So I knew something was up, and the next day I drove myself into the Kelowna Hospital and ultimately received a series of tests where they determined that I had a severe blockage of my left anterior descending artery. And so the cardiologist sat me down, gave me a one-pager on stenting, told me I needed to have a stent, and within a few days, I managed to get a complimentary airplane ride to Vancouver, and my stenting procedure was the last one of the day, and I received the stent it came in through my wrist, and which another cardiologist later told me it was a party trick. But but at any rate, I'm lying on this procedure table. At the end of it all, the cardiologist said to the nurse beside him, "I really don't believe in stenting, except in cases like this." And I'd still like to know what he was referring to.
So situations differ, and in Dawn's situation, obviously the treatment needed to happen very quickly, but there are certainly circumstances where people have a little more time to be more informed and to feel more confident about their decisions so that they can participate and play an active role in the decision making. And in fact, a theme that came out from our engagement with healthcare providers and with our patients and families was the need for credible, tailored information to help people feel more confident and better prepared to make those informed decisions. A critical time that was identified was prior to elective angiography, because this is when people are often diagnosed with the coronary artery disease. And patients and families told us that sometimes as they went into that appointment, they weren't unaware that they might have to make a heart treatment decision right away, that they might receive a stent right away, or that they might have to decide on surgery. So they wanted web-based health literacy resources to support them. They wanted that information to be developed by patients for patients, to answer questions and concerns that were really important to them. And so because of that, and knowing that, we had patient partners as part of our planning committee from the outset, working with decision makers from Cardiac Services BC, healthcare providers, and with researchers like Jess and I to support that planning of putting a workshop together. We put that workshop together at a time that suited stakeholders. They chose early evening. And we used a WebEx platform so people could participate across the province. And we used a pre-workshop survey so that we could prioritize the resources that we were going to work on in the workshop, and so we understood what people were hoping to get out of this. So we really knew what the expectations were. This is the stakeholders who were involved and participated in the workshop. They were diverse. And it was a 3.5-hour workshop. It was facilitated by a graphic facilitator who supported us in making sure we had a shared vision. And then we broke up into working groups to work on 4 resources. 2 of those working groups participated virtually, and each working group was mixed in terms of participants. There were 4 templates or plans that we put together: pros and cons and risks and benefits of treatments, accessible treatment information, plain language summaries of evidence, a preparation checklist that you could choose from and print so you had the questions ahead of time before you went to see your physician, and Mythbusters to deal with common misconceptions about heart treatment. We evaluated people's engagement using the public and patient engagement questionnaire, and 100% of people agreed that they thought the workshop would make a difference and that they were able to express their views freely, and 90% felt that their views were heard. One of our patient partners said the best things were that I was able to get my views known and heard by cardiac professionals, and that I was able to participate from a distance. At the end of the workshop, people were invited to continue to work on these resources and complete them. And Jess is going to tell us a little more about that co-development process.
Great. Thanks, Kim. So as she said, after the workshop, we actually had 7 patient partners, 4 clinicians, and 2 researchers who helped finalize the final products. Now, given geographical barriers, we had to rely quite heavily on a number of different communication tools, some of which included Google Docs, Skype, email, and teleconferencing solutions. But after 3 months of fine-tuning the materials, a final draft or beta version of HeartHub.ca was ready to be unleashed on the world. Now, the next step in our process was to evaluate the website on a willing audience. We did that by taking 2 iPads into the cardiac unit at St. Paul's Hospital and simply asked patients to review the website prior to their angiography appointment. And as you can see from this infographic here, our results were quite positive. About 3/4 of the patients felt more confident and more prepared to be involved in making a treatment decision with their physician. And about 90% of them agreed that the information was easy to understand. Some suggestions for improvement included the inclusion of more female-specific information, as well as the addition of multiple languages. That being said, the most consistent finding, or our key finding, was that patients alerted us to the fact that we weren't reaching them at the right place nor the right time. So patients needed to be made aware that this resource existed prior to planning their hospital visit. And as you'll see later on, that's exactly what we did. Needless to say, this entire experience was very enlightening for all those involved, but I think we can distill it into 3 key take-home points. The first being that co-design is a balancing act of time and resources, and that building and sustaining relationships. We had to make ourselves available sometimes at the drop of a hat for any team member, and we had to come up with some creative ways to stretch a dollar. Second point we want to make is that co-design projects and teams need to be very flexible and well supported, whether that be financially or with regards to time and volunteer commitments. What I do want to recommend is looking inwards and tapping into your own human resources just to see if there are people who are already skilled in graphic and website design, because these services can be quite costly if outsourced. Finally, we really want to make an important note that you should focus on both the process and the outcomes, and to use check-in points along the way to help mitigate any concerns or loss of engagement. Now, that being said, you will lose people along the way, and that's okay. That's all part of the process. Now, all of this information might have you thinking, what's next for HeartHub.ca? Well, as I alluded to before, we have engaged triage coordinators across BC who have agreed to include a link to the website with information that goes out to patients prior to their angiography appointment. You'll also be able to see the website link on numerous hospital and health authority websites across the province. What's more, we polled cardiac professionals across BC on the top 3 spoken languages in their units, and from that we were able to make the website available in simplified Chinese, Punjabi, and Farsi. Another point we're trying to make, we're trying to spread the word, and that's exactly what we're doing in conferences such as these and in hospital meetings to make clinicians and other patients aware that this resource exists. And finally, we've put together an advisory committee of both patients and clinicians to review the website every 6 to 12 months just to make sure that it's still serving its intended purpose. In closing, I think it goes without saying that this was a tremendous team effort. We would not be able to stand up here today if it weren't for all the patients and health professionals who so graciously shared their time and perspectives. We cannot thank them enough. With that, I'd also like to thank you for allowing us to share our story, and we'd love to answer any questions you may have. Thank you.
Very impressive in the way that both the design and the results that you got and how you did it. Yeah, so questions from the group? Any questions? Yes.
You briefly mentioned the use of Skype. Was that for some kind of virtual interaction between clinician and patient, or was that clinician to clinician?
Yeah, great question. It's actually between the patients. Most of the clinicians were either phoned in, so we were able to grab them when they were either coming in and out of the hospital, but in terms of Skype face-to-face interaction, that was researcher clinician with the patients. So the patients that were either in the interior or on the island or otherwise in BC.
Did you face any barriers with that? I do virtual connections with Skype for Business a lot with our clinicians at St. Paul's, and we faced a number of different barriers. I'm wondering what you guys have faced. Sorry to be very specific on that.
No, it continues to be a challenge. I know where I am. We were really fortunate. I didn't mention that when we did our webinar connection, we actually gave people the opportunity to get technical support both before and match up and everything. And then even during, we had a millennial who was supporting us online through the whole thing. And so we tapped into that. We had someone who was supporting that and was able to support and help that, because you're right, even with Skype for Business, there's something that needs to load onto the system. And that can be a challenge. So we had to be super flexible. Sometimes it was just a phone call.
Yeah, great question.
Yeah.
Hi, I'm Isabel Jordan. I'm a patient partner. I noticed in the handout that you used the Patients Included Charter. I was wondering if there was anything that was more challenging or easier about using that for engaging.
Thanks, Isabel. That's a great question, because one of the things you'll see from you saw rather, from the graphic facilitation is that patients wanted information to be at a grade 5 or 6 reading level. And we really struggled with that, and we needed to really lean on our patient partners to help us make the information more accessible. So translating it from a clinician language that, for anyone really, it's complicated in itself. So we were able to explain it to them in plain language, and they could distill that back in a language that they thought the mass public would be able to understand. So for us, that was our barrier, our struggle in trying to make it accessible. But we think working with patients really helped us to make it that much more accessible to the public.
Oh, hi. Doug Bell with the Canadian Medical Protective Association. It's interested, who and how did you decide who your patient co-design partners were going to be?
The word went out through a variety of means. It was put out to the people that we originally contacted from our focus groups. It was put out through the different health authorities and obviously through the Patient Voices Network. So we didn't turn anyone down. Everyone was invited who wanted to be included. We suggested that if they had a heart treatment decision, that would be ideal. But there were a couple of people who maybe had family members, and that was how they got involved as the patient partner, because they felt on the basis of that experience they had something of value to share.
Other questions?
Do you know what the uptake is there, like unique hits on the site, or how many people are actually going there?
Yeah, we do. So we have, it's just a basic WordPress website. So there's a lot of Google Analytics involved in that. So we can see just how many people are hitting it on a daily basis. When we did our soft launch in July, last July actually, it had spiked massively because that's when we had blasted everybody with emails saying, please visit. There's a pop-up that says, give us your assessed perspective on the website. So from then on, we then translated it into 3 languages. And since then, the numbers have been rapidly increasing. And from the last 3 months or so, as I said, we've been working with the triage coordinators who have been sending out the link to all of their patients beforehand. So that also helped with the massive spike in audience. And as you saw, I think our volunteers here were passing around the little cards. Some of those are even sitting in VGH's cath lab waiting room beforehand. So it's really the awareness that we've worked on getting the word out has really increased the audience for the website.
Did you have a multicultural group as a part of your co-design? Because when you translate it, some of the content might not be culturally correct. So I'm wondering, yes, it was done in English and then translated, but was there some cultural translation done as well?
Yeah, do you want to, you can start.
Okay. Yeah, so we did in fact, and we were very fortunate to work beside Jeff Redding, who is the Indigenous Heart Health Chair. So we made sure that we did include a lot of that information. There is a subsection of the website that says if you identify as Indigenous, here are some key resources that you should view. And in terms of the language, we were also very fortunate that at the BC Centre for Improved Cardiovascular Health, we have a diverse group there too who have gone through and looked at the Farsi and the Punjabi and the simplified Chinese, just to make sure that what we paid for in terms of the translation was in fact well suited to the purpose.
But it's a very good point. I mean, one of the challenges when you have limited budget is it would have been, the ideal circumstance would have been a way to have different groups that we consulted with in the co-development from the start. And that would have been one of our limiting factors, is if we could have, run a Mandarin group and that would have really helped us. But that's where we start to have those compromises we do along the way.
Hi there, my name is Sean Spina. I'm a pharmacist clinical lead at Island Health, and we just put out 6 cardiac drug videos, if you will, and they've been used actually around the world, which is fantastic. And I'm happy to connect with you guys to see if that's helpful to just share with you guys to post, because our goal is to hit patients around the world, but obviously in BC first, and if that's at all a possibility, happy to chat with you.
Absolutely. I was going to say at the end of all this, when you kick us off the stage, to do a little sales pitch. If you have any information, links, or resources that you think would be helpful, by all means, connect with us. We're constantly modifying the website, adding new things that we find along the way. So that would be a great resource to add. Thank you.
For sure.
Any other questions? Well, thank you. That's a very
Thank you, guys.
Our next and final presenter is Liz Lamb, talking to us about new design for autism, meeting autism needs.
Thank you. Thrilled to be here. This has been my favourite project over the last 6 months. And it's called Getting the Balance Right, and BALANCE stands for Building Alliances for Autism Needs in Clinical Encounters. It's a bit of a mouthful, but we have to have something that works. I am the Quality, Safety and Accreditation Lead for the Surgical and Procedures Department at Children's Hospital. I have nothing to disclose, and I also want to say I have nothing to disclose about the fact that I am not an autism expert in any way. That's you guys. The first thing we really had to do was acknowledge that we have a need for change, and we've had some really bad encounters with children with autism, with families, and we know we haven't done a good job. We've seen that we've had to sedate children in the car, in the parking lot. We've been kicked, we've been punched. We've clearly not understood the needs of the families. We've had children running away from the department. So we really knew we had to change. What we did do back in June 2017, we did a patient journey mapping event where we asked families what was their experience of surgery. And quite a few things came through in that. This is just a really brief summary of what the families said. To start with, they were very concerned about the route of anesthetic. Are we going to use an IV? Are we going to pin their child down to put a mask on to give them an inhalation anesthetic? This was all very worrying for the families. They also said sometimes they'd arrive in the hospital and they had a plan that worked really well for them last time. And then we ignored that plan. And we said, no, we're going to do it our way. The families described this very traumatic period of time when we were trying to get their child off to sleep for the general anesthetic. And what we heard from the families was that they told us that they heard things like, if you don't behave, we'll send your mum out. So really, we knew that we were doing a really bad job with a group of patients that we really could do better with. Because of the upsetting and traumatic, sometimes, induction of anesthetic, we saw families upset, crying on the floor, not knowing what had happened, requiring a debrief, really, of like, what could we have done better this time? And we failed those families every time. We kind of said, off you go, thank you, bye, we'll call you when we're done. The other thing that we saw, and we came through loud and clear from the families, was that if a child's upset in the post-op period, we try and get them home. So we try and push them out of the door as fast as they can, thinking that we're doing the best thing as providers to get them home. But this was what the families said, this wasn't what they wanted. They felt like a burden to us. They felt like they were inconveniencing us. And some families actually described waiting in the parking lot after discharge because they were convinced they'd have to come back straight away. So this was all helping build our case really for we needed to do something different. And also when we spoke to providers, they felt they had let the families down if this happened. So this was a really interesting piece. We kind of asked around informally, and no one had ever had any training, any education, any real proper experience of how to look after children with autism and what to do best. So we needed to improve, clearly. What we did after this was we heard about a program in IWK, and that's in Nova Scotia, in Halifax. They had been building this program, Balance, this is their program, and they had developed this with input from parents, families with autism, children with autism, researchers, clinical psychologists, frontline staff, caregivers of all kinds, and they developed this program really in partnership with the families. So the first we heard about it was an anaesthetist came over from Halifax to BC Children's and said, hey, we've got this great program to help educate the providers and to help that transition through surgery. So we started to build this connection with IWK, and I'm the Pacific representation today. They couldn't get here, but they would have loved to, really to talk about how we started partnering to get this program implemented into BC Children's. So what is the Balance program? 7 online modules for healthcare providers. And these have vignettes, even with children with ASD, which is so cute when they're telling us directly what they need and seeing the difference. Like, everyone's got this unique need, really. Part of the Balance program, and this is really key and what's really helped us, is to have a sensory, emotional, and a communication assessment of the child. As well as that, we need to put some things in place for the day of surgery. So this is the creation of a toolbox, if you like, a distraction box of all kinds of things that may help on the day of surgery. So the balance assessment is really what was new to us and has been so valuable and so helpful for all of the team. So this is just an example, and I can give you a copy, or you can go to the website to see more. But on its own, you need to have had the background of the online modules and things like that to really get to know how to use this. But it's kind of split up into those two areas. We have an assessment and approach. And for the sensory piece, we may have things like, what have we got up here? Maybe the textures are a trigger. So maybe we want to have them wear their own clothes on the day of surgery. Maybe it's noises or bright lights. Maybe we can turn the lights down in the rooms. Maybe we can restrict traffic coming in and out if they're worried about so many people. Some of the emotional pieces were, and this is really helpful, you can see the little traffic lights here. The families could tell us what it looks like when the behavior is escalating, which is something that we've missed every time. When we look back, we've always missed this. So they can tell us, you know, what does it look like when my child's calm? What are some of the first signs that we're going to see of something escalating? And when we get to red, it's stop. And this would have certainly helped us for that time that I remember a boy running out of our department because so many people had been into his room who he didn't know. That was like the last straw, and that was it. And then the communication piece, we have some children who are nonverbal, some are very chatty. So this helped us really figure out what do we need to know about the communication needs of that child, and then what can we put in place. So there's all kinds of helpful tips in the approach section, such as using that concrete language. We're going to do this and then this. Or we may have little pictures that can show children what we're going to do next. So building a case for balance, it started off as a research project at IWK. We originally pursued that option, and it got very difficult because we were trying to work between two sites. So we decided to build on what they had found in their research and their implementation in a small area. And we said we'll use a quality improvement approach so that we could see how that program is going to translate to a bigger tertiary centre. Both together then, we're going to do the program evaluation so we can really see what difference it's made. And the point is we want to share with IWK what we've learned on implementation so they can start to spread that to other places too. Ultimately, our goal is to support children from admission to discharge as smoothly as possible. So we've all got the same goal. We're all on the same page. So quality improvement, we use the model for improvement, keep it simple. Our aim was to offer the balance assessment to 100% of families of children with autism. That was our original goal. We have a whole bundle of measures in there that we want to kind of track somehow, and we want to share that with IWK. So we want to know the number of assessments that we're actually doing, the uptake from staff as to who's doing the balance modules online. We want to know about healthcare provider attitudes and behaviours as a result. So IWK saw behaviour changes at around 6 months. So that's what we're going to be looking out for. We also want to be asking the families, how did this work? And that's really key. So what we want to do is have a follow-up phone call and start to tease out some of those pieces of, you know, did it work for you? The changes that we identified were very kind of practical and process-driven. How are we going to get to identify these families in the first place? How are we going to do the timing of the assessment so we have actually time to go through this with the families and talk about it? And then how are we going to share that information with the team? And that's been the hardest piece actually so far. We've done lots of PDSAs about how are we going to get that information to you. We're still working on it. So the PDSAs really have been, has it been working? Did you get to know about balance? Did you see the balance assessment in the chart? What did we put in place? So the way we implement it now, this is how and it's only recently that we've been trying this out. 1 to 2 weeks before surgery, we have a pre-screening phone call. So a nurse will call every family. What they want to do at that point is try and understand, is this relevant to have an assessment, a balance assessment? So they will offer that balance assessment to the families who've got the diagnosis. However, some families are just saying, nope, I'm fine, everything's fine, my kid's very chatty, they've been lots of times before, everything's fine. We've also seen families who've said, well, my child hasn't got a diagnosis, but we would benefit from going through this assessment with you. So we have been kind of using it like that. Based on that assessment then, that gets translated to the surgical slate. So now the whole team can see, they'll see the word balance tool, and everybody will know to look for the assessment in the chart. So before we start going into the rooms or introducing ourselves, we want to have a plan. And then the follow-up call, every day, one day after, every family get a phone call the day after. And we're asking 3 things now. We want to say, did we offer you a balance assessment? What did we do? What were the interventions we did on the day? And did they help? So we're hoping that that will just be a few short sentences that we can start to build, and we want to share that back. So the way we've been promoting it, it's been a slow build. We want to use a champions model, so we're looking for those informal leaders. We're looking for people to come forward. And so far, 12 people have come forward as champions, which is amazing. We have representation from child life, anesthesiologists, nursing, the OR nurses, the pre-op nurses. It's been really great. We've created these infographics so we can share the word, really, make it really simple. Everyone will get a pin on completion of the modules, which is a nice little yay, I got it. And we also want to start, when we start getting the data in, we want to make sure we report every week what's been happening. And that's really key to kind of driving it and building that momentum. And we really want to find a robust way of drilling down with some of these families. So we want to ask, if families have got more to offer, can we talk to you? Can we interview you? Whoops, I think I missed one. Results. So only since January I've got any results. I was hoping for that a little bit earlier, but hey. 44 children with autism undergoing dental surgery were identified. 26 balance assessments happened. 8 of those children, interestingly, didn't have a diagnosis of autism. And so when we broke that down even more, we had ADHD, anxiety, nonverbal behaviors, all these kind of things where we saw a whole subgroup of patients who have really benefited from this. And then this quote was from one of the mums who was very grateful that we had at least tried to do something a little bit different. And even though this mum was very experienced, she's an autism specialist herself, she actually said that this is going to be really good. So we're really hopeful that this is going to work much better than the systems we have. So the lessons that I learned, certainly as we've implemented this, I am not a very patient person. I kind of like things to move really quickly, and the discussions first started in June, and I've had to really allow the champions to start leading this and to build it up at the grassroots. I think that's the only way we're going to sustain it, and it's the only way we're going to kind of build that momentum. It's been hard. I've been sitting on my hands so much. But this is really, it has to be kind of built up and driven. The other really interesting piece was that we found that the balanced assessment wasn't just going to be used for children with autism, which is fantastic. When we spoke to IWK, they said this was their experience as well, and that certainly there were many families that benefited from this. And we're only pediatrics. You know, if we think about the adult world, we could do a lot better as well there. My tips for kind of getting things in place were really build on the processes that we already had. So I was trying not to overload anybody with an extra step of something, because I think we'll miss it. So we tried to, at the pre-op screening, we said, okay, is this an opportunity to do it? Day of surgery, it's just too chaotic and we're so time crunched that we couldn't do a good assessment. So we made sure we did this ahead of time. The other one, we already do post-op phone calls, so that was a case of adding a few more questions in. And because we have balance tool written on the operating slate, we can go back and we can see which are the families that have had that. Thank you for listening. This isn't our program to own, but IWK have given us permission. Please go to the website. They have a little blurb about what the Balance program is there. And if you have any questions at all, they'll be happy to answer them. If there's anything I can answer here, I will try. Thank you.
Thank you, Liz.
You're welcome.
Questions? I'm sure there are. It looks like there's a bunch. So.
Okay. That was really great, thank you. And 2 points that I want to make here was, the first thing is that it's great that you adopted something from somewhere else that they developed and used it in BC and used it really well, looks like. The question that I had was, do you also, I know you do like a post-op call for the parents, but do you also do like a little huddle with the team to see how it went, where the assessment was?
That's a great suggestion. We do safety rounds once a week, but I think if you're talking about huddles, they're more in the moment. I think that's an excellent idea. I'm going to put that to the champions, and I'm going to try and sit on my hands again. Thank you.
Good morning. My name's Beverly Pomeroy. So I'm a patient partner. I have a child. I had a child that had a complex health need, and I just want to say thank you. This tool is extraordinary. I wish that we had it in our health journey. I think we were frequent flyers.
Yeah.
And you know, thank you so much, because I think this can be used for parents that have frail youth, that have complex disease process, that have you know, families that are dealing and that are being their champions. So it's not less of a question, but I really hope you figure out, not sit on your hands, but really implement it throughout the entire hospital at BC Children's. I think it could be a tool that would be really, really beneficial to families in their extensive journey that they have. So thank you so much for that.
Thank you. That's really encouraging. Thanks.
Hi, my name's Diane. I'm a patient partner, but I'm also a volunteer. Is this questionnaire just for Children's Hospital, or is it also over like at Victoria General, which has all the
Are you talking about the balance assessment and the balance modules? So we kind of came to an agreement with IWK because it was a unfunded research, isn't that always the case? They're trying to get some money back, so they're trying to promote their program. So what they will be looking at is how health authorities can pay for that. The deal that we kind of went into with IWK was that we would help implement it in our program. We would share all our learnings, all our anonymized data with them to try and improve this. But for now, it's just in the surgical department. But that does now include all the pre-op and all the post-op, but it's only at children's surgery right now.
Okay, because my question is I volunteer for the day surgery and for the child's induction, so I accompany the parents and the child down. So I have like no skills and very little knowledge given. And I have to spend maybe up to an hour helping this child, and the parents are stressed, and it's I usually end up leaning on the anesthetist, saying it's your job to make calm, right? But can you also include in this that the volunteer who has to
absolutely
is given some kind of information?
That's a really good point. One of our volunteers, I said, are you interested? And she said, you betcha. So again, it's a case of getting the champions to actually have time to do the online modules and to start to promote it within that group. I just really want to facilitate that, but I will go back to our volunteer and say, hey, were you serious? Because it would be really good if we could have volunteers included. Yeah, we just have 1 or 2 a day at the moment.
We don't have any skills.
Yeah, same with the nurses. Yeah. It's a big gap.
Hi, I'm a healthcare provider, but I'm also the mother of a son with autism. So I just want to thank you from the bottom of my heart for having a program like this. I do want to encourage you to, as a program, look at all of those different diagnoses that could benefit on top of that, because it actually took us 9 years to get a diagnosis of autism.
Yeah.
Where early on, I suspected that there were multiple different things happening, and he had multiple of those comorbidities occurring, like ADHD, sensory processing. But also, I think there's a lot of children with anxiety out there. I think of my daughter, who actually would benefit from this even more than my son, who doesn't have any of those diagnoses, but certainly would have benefited. So I encourage you guys to consider broadening that umbrella of the assessment questions, and really asking the parents who has a sensitive child out there, or one really that would benefit from a broader assessment ahead of time, because I think in the end it will only benefit your team, but also the entire patient and family experience, and perhaps even broadening that beyond surgery, but all the different tests and procedures that children have to go through. I think back to him having an EEG, for example, and the weeks and months that we waited to receive that test. There was no general anesthetic involved, but it certainly was an experience that did heighten his anxiety and that of the family as well.
Absolutely.
So thank you for
I
what you
would
guys are
love
doing.
to spread it far and wide. And we do
I will
have...
happily be an ambassador.
Can I see you afterwards? Absolutely. Thank you.
So I just want to thank you for your courage in sharing all of the issues you were having at your site. I think that's true quality improvement, and you can't get to coming to a resolution until you can face up and be open. That I think that takes a lot of courage to talk about the awful situations you were experiencing openly, to know you needed to change. So thank you for that. And also, I mean, reiterating what a lot of people have said, that I think this has applicability for so many patient populations. I would almost say that it should be the standard for every patient, because I think, you know, everyone has their anxiety, or they need more information, or they might need a special way of approaching them. Some more than others, some fit into our system a little better than others, but irrespective of diagnosis and irrespective of age, I know, like I can think, having worked in geriatrics, that patient population would probably also benefit very much.
Good point.
But I guess my other question is, was this used for only elective surgeries, or how did you integrate it into more urgent surgeries?
We haven't integrated it into urgent surgeries, and there's a gap. So looking at how we can get the assessment done in a good, timely way has had to happen at our pre-screening process, so a week or two out. So currently it's just elective surgeries. I would love, this is so encouraging to hear the feedback in the room, because I think now, you know, we want to get the lessons learned, we want to share it with the staff and the families, and we want to say, what next? Where else can we build this in? So it could be that we send it out to the families. It could be that we get it and emerge. I don't know, you know, but all to say, I agree, and I think it should be spread out. And I love the idea of, let's do it for everybody. Yeah.
That was awesome, Liz. And I think you've already answered my question from some of the other answers, but I just wondered if it had spread. So if these dental surgery patients are admitted, does that go upstairs right now? Probably.
Yes. So what we've asked for, at first the scope was very tight. They said just daycare surgery. And we said, well, our surgical patients go to the wards afterwards. So the kind of contract that we signed now extends up there. So it does mean that the nurses on the wards, on the inpatient wards for surgery, will be able to access this too. I'm thrilled about that. But we have to kind of start somewhere and get it built up. Yeah.
Medical floors too, but that's
spread. Yeah. Yeah. I just want to say as well, I know you said it was brave of me, but it was actually brave of the families to tell us this. Because if we hadn't have heard that from them, we would not be here right now. Yeah.
I'd like to make a point. You said you're not very patient, but anybody who works with children, especially with autism, my hat off. And the second question is, what surgeries do you do besides dental surgery?
We do all kinds of surgeries. So you name it, we do it. Yeah. I can't think of anything that we specifically don't do at our centre, but when we looked at the dental population, that seemed to have the highest incidence of these families, and we knew we were failing them. So we did start with the dental surgery families, and now we want to spread it to everybody. Yeah.
Hi, Liz. Thank
Hi.
you for that. That was really good. So coming from the same field that you are in improvement, I was thinking, yes, we need to move this now for, like you're saying, to everybody to maternity. And then I just suddenly realized from my own personal experience, I had an accident a few years ago, and I was in a situation I cannot remember anything about it, so therefore, thankfully, I never want to. Somebody came back to me and said that there was a period of time that they needed to do a scan on my head to see that I had a brain, but to see that it was an okay brain. And I was fearful. I don't know what I was doing, but they were threatening that they would have to anesthetize me. And I'm thinking something like this would have. So I'm reiterating what other people are saying. I do apologize, but just saying like an emergency, yes, and not just for the children, and great for them, but everybody else, yes. It's an incredible
absolutely.
setup.
I hope
Thank
that
you
we
for
get
this.
faster and slicker at doing this and asking the right questions at the right time. Yeah. Okay.
Your questions? I actually had a question, which is, what was the most, and I actually, for each of the groups, we've got a few minutes, about 4 or 5 minutes left, but what was the most surprising thing in doing this work?
The surprising thing for me was realizing that nobody had any training or education in this. There wasn't anything out there. And we were like, how come we've gone through all our training without any mention of this? Yeah.
Thank you. Thanks. And for the same question to our other groups? You have a...
I thought it was as much surprising as a shock, or that we knew that patient preferences are so diverse, so much so that when we sent out polls to get people's votes on things, they always came back a 50-50 split on everything. We always had to have a tiebreaker because the views the perspectives were so diverse. So that, I think that just went to show that, you know, what we think is necessarily correct is not what everybody else thinks as well.
Thank you. Other? Andy or Rosemary, any? Probably lots of surprises. Might one have been. They're trying to agree on which was the biggest. Yeah, the most surprising.
So sorry, I had to run out, but
Yeah.
this might have been asked. So my son doesn't have autism, but this kind of approach would have really helped him many, many times. Would this be generalized for other kids or for kids with other needs?
Absolutely. I think that's what we were seeing when the nurses were doing the screenings. They weren't always looking for the patients with autism. They were asking the families, you know, is there anything we need to know about this? And sometimes there was a cue around, maybe it was communication or maybe anxiety got mentioned, and then that would kind of prompt the nurses into doing the balance assessment. So I think we're learning as we go. I think the nurses who are doing the screening are starting to listen for the right cues, and hopefully when we get the feedback from the families more, we can reinforce that. Are we getting it right? Yeah.
Thank you.